So thank you for that introduction. That's great. I don't have to do much of an introduction myself. I'm really happy to be here talking to you about cervical cancer prevention in resource-limited settings. And what I want to focus on is just sort of an overview of the disparities in the global burden of cancer with a focus on the global disparities in cervical cancer, both incidence and outcomes. And then I want to review some of the evidence behind prevention strategies that have been developed and studied for low resource settings. And then really talk about some of my work, some of the earlier work that I have been doing. I started working in Western Kenya about 10 years ago. And so this talk is going to be just a brief overview of what I started doing and then the projects that we're just embarking on with R01 and hopefully explain how I got from one place to another. All right, so we'll start with the global burden of cancer. Overall, everyone in this room, I think, is interested in global health. And one of the first things we need to consider when thinking about global health is what are the burdens of disease? Where can we really make an impact? And what should be our targets? Well, cancer is the #1 killer in the world. Although HIV, malaria, and TB probably get a lot more attention in public health, there are more annual deaths attributable to cancer than to all of those three combined. It's the leading cause of death in developed countries, which many of us are probably aware of, but most of us probably don't recognize that it's the second leading cause of death in developing countries. Along with other non-communicable diseases, cancer accounts for about 2/3 of global deaths annually. That amounted to about 13 million new cancer cases in 2010, with almost 8 million deaths attributable to cancer. There are still more cases in developed countries compared to developing, but there is a greater mortality rate in low-resource countries. So there's about 70% of the deaths are in low-resource countries. The burden of disease is shifting to low and middle income countries. That's due not only to the growth in the aging of the population, which is overall a good thing, but also to the entrenchment of some modifiable risk factors like the Western lifestyle and diet and increasing tobacco use in those countries. The global burden of cancer is going to increase. The WHO estimates that by 2050, just using estimates of population growth, there are probably going to be about 24 million cases of cancer globally with an increased proportion in low-resource settings. And just to think about how that impacts these countries and acts as an overall public health issue, 70% of the cases within the next 5 years will occur in countries, do you need me to speak up, that spend less than 5% of global healthcare dollars. So this is not unrecognized by program planners and international policymakers. At the United Nations Summit on the Sustainable Development Goals last fall, there were multi-pronged cancer prevention and control efforts included as part of the new Sustainable Development Goals for 2020. Ban Ki-moon has described this cancer and NCDs as a global health emergency happening in slow motion. So this slide, just briefly I wanted to illustrate that the cancer epidemiology is different between high resource and low resource countries. Historically, and still for the most part true today, cancers in low resource settings are more attributable to infectious diseases or cancers that would be prevented by screening, like cervical cancer. And then if you look at the most common cancer sites in women, which is on the left-hand side of the graph, it's dominated by reproductive tract cancers, breast and cervical. This demonstrates that graphically throughout Africa, cervical and breast are the most common causes of Africa. But if you get to the region where I work in East Africa, cervical cancer really dominates as the most common cause of cancer-related death in women. So I think cervical cancer is, I don't know if ideal is the right word, but it really is an ideal case of a global health disparity that's related to both gender and economics. It's the 4th most common cancer in women worldwide. It doesn't even make the top 10 list in most developed countries, so this is really attributable to cases in developing countries. In 2012, there were over 500,000 new cases of cancer and 266,000 deaths. So we hear a lot about maternal mortality. There's a lot of attention and funding given to maternal mortality. There are as many deaths from cervical cancer as there are related to women dying within the year of being pregnant. So I think it is an important but maybe under-recognized public health problem. And unfortunately, unlike other diseases where we have a screening and prevention strategy, we have a vaccine, and that vaccine is becoming more widely available in low-resource settings. The WHO predicts that cancer incidence will continue to increase, and they estimate about a 20% increase by the year 2030. And that increase will probably continue to disproportionately impact low-resource settings, where 88% of the incidence and mortality occur. In other ways to frame that, a woman has about a 5 times greater likelihood of developing cervical cancer in a country like East Africa compared to the US, and about a 10 times greater risk of dying from cervical cancer. This shows what I said in a map form. The colors are a little washed out, but the dark countries shaded in blue and dark blue have higher incidences of cervical cancer, and you can see that's pretty much concentrated in the developing regions of the world, with the highest focus here in East and Sub-Saharan Africa. And the same pattern follows for cervical cancer mortality, where red and pink are the countries with the highest mortality rates, again, developing countries, Sub-Saharan Africa and East Africa in particular. To really drive home this point, this graph shows the cancer rates, gives some numbers to it, but I think the pattern is also important. In the middle of the graph, you get the incidence rates for less developed regions overall, and it's about 16 per 100,000 women, with about 6 deaths per 100,000 women. Compared to that, in East Africa, the incidence rate is 43 per 100,000 women, with 28 deaths per 100,000 women. And then here you can see North America is doing a lot better. The incidence rate about 6, deaths about 2. Why is that? Because women aren't getting screened. We have effective screening and prevention methods, and they are not being offered, but they're not accessible to women in many of these low-resource settings. So this map just shows how common effective coverage of cervical cancer screening is throughout Africa. This bright blue color represents the percentage of women who have never had a pelvic exam outside of childbirth. And then the light blue on the left, or the right-hand side of the graph, shows effective coverage. So no country in Africa reaches even 25% of their population having effective coverage. Effective coverage would be defined as effective screening tests coupled with treatment for women who need it, and then the appropriate follow-up. Kenya, where I've been working, is about 5 to 8%. So why is there this disparity in screening? We could just simply say it doesn't happen, but why isn't it happening? So I think, as with many issues in global public health, it's a financial issue. The healthcare resources aren't there. The healthcare infrastructure may not be developed enough to support screening programs. There are also competing health priorities. Many countries in low resource regions of the world don't prioritize women's issues. Women lack empowerment in these countries. They haven't really had advocates for reproductive health or their healthcare issues. And then there are the more pressing other health issues that affect this country, like infectious diseases, diarrheal diseases, respiratory illnesses, and then the epidemics of HIV, TB, and one other. There's a lack of a preventive health model. In many of the sites where I've worked, people don't see a visit to the doctor as something they do while they're healthy. So even when screening programs have been introduced, it's sometimes been difficult to convince women that you would go while healthy to get diagnosed with something that tells you you're sick. There's differential cancer epidemiology, like I briefly mentioned. So that has a two-pronged effect. That means that cancer outcomes are different depending on what the type of cancer is. But if the epidemiology in wealthier countries reflects certain cancers, those cancers are more likely to have more funding towards prevention and treatment than the cancers that impact low resource settings. And then poverty. So not just the difference in poverty between wealthy and poor countries, but within poor countries, wealthier women are more likely to be able to access healthcare services and screening than poor women. And in many of the countries in sub-Saharan Africa, 80 or 90% of the population lives at less than $1 a day. So the majority of the country, of the women within the country, live in poverty. So those are the overall challenges to implementing a screening program. But specific to setting a screening program up, there are certain space and infrastructure requirements. If you guys think about when you've been screened, or maybe some of you are young enough to never have gotten screened yet, when your partners have gotten screened, what it entails. You have a doctor that you know about, or a nurse practitioner, you have insurance, you can get an appointment, someone's at the clinic or the office when you go. There is a clean exam bed, a speculum that's available, a light source that's available, there's equipment to collect the specimen, there's someone that processes the specimen, it goes to the lab, a cytotechnologist reads the pap smear, a pathologist approves that reading, there's some tracking system that gets the results back to the doctor, that gets them back to the patient, and then there's an even more complicated follow-up system if that test happens to be positive. So that is a very effective but very resource-intensive screening strategy. And it has decreased the risk of cervical cancer in the United States to the levels that we saw on that graph earlier. But it's incredibly, it's not feasible in most resource-limited settings. So, where do we start with what are the challenges? There's poor transportation. These settings often lack roads. They lack transportation options when there are roads, meaning that patients can't get to clinics, specimens couldn't get to a lab. There are poorly supplied clinics. Many clinics don't even have exam beds, let alone speculums or lights, gloves. There are low numbers of trained staff who would have the ability to counsel or carry out screening techniques. There's a lack of laboratory infrastructure. There are a very limited number of pathologists in Kenya where I work, and there certainly are not pathologists in the region where we're implementing cervical cancer screening. There's a lack of computerized tracking systems. There's medical records all take place on papers that are left with the patients. So there are logbooks in the clinics, but the patients often carry a little card with them that has their results. So it's not a system in which you can overlay results from a laboratory. And then there are the inherent limitations in space, water, and electricity that impact all health services. Okay, so there's not just challenges. Those challenges lead to ideas about what would be optimal screening characteristics. Keeping in mind what we just saw as the challenges and the reality, a screening test would be optimal if it could minimize the patient burden. So if we could get a screening test that allowed the same day results, we could either immediately refer a woman for treatment or even provide treatment that same day. The treatment should the screening should definitely be low cost and have as minimal infrastructure requirements as possible. I learned over the last 10 years there's nothing that has no infrastructure, and even to say a minimal infrastructure requirement might be an optimistic phrasing. It needs to be an easy to learn and administer test so that it can be performed by non-physicians and they can be confident in performing it, so that doesn't hinder their willingness to perform this. It should have a straightforward interpretation. It's positive or it's negative, and they can understand what that means and what to do with it. And the screening strategy should have adequate sensitivity and specificity, so it could be coupled directly with treatment in a screen and treat program. So until about 10 or 15 years ago, there was not a lot of attention to cervical cancer screening, and that's what led to the disparities in the statistics we saw earlier in the incidence and mortality from cervical cancer. In 2006, WHO published their first guidebook on comprehensive cervical cancer control. And some of the interest really stemmed from the HIV epidemic and the international donor response to the HIV epidemic. Not only because HIV increases a woman's risk for cervical cancer, but because the healthcare infrastructure necessary to address the HIV epidemic was bringing primary care or primary care-like centers to areas of the world where there was no access to care before. So in 2006, the WHO pretty much produced a handbook. They didn't recommend one strategy over another. They said if you have the resources, you could do either one of these three things. If you want to couple it with the diagnostic step, which means colposcopy and then a biopsy, here's how you could do it. You could treat with an excisional procedure, which is called LEAP. You could treat with cryotherapy. So it was really a handbook instead of guidelines or recommendations. And the reason for that is there wasn't really any evidence for these strategies because they hadn't been tested in resource-limited settings. So to review the three, given the limitations and the optimal characteristics of a screening test, we could see right away that cytology screening would not be feasible. The next option they presented was visual inspection with acetic acid. This picture is a cervix, for those of you who are not medical or not gynecologists. Visual inspection with acetic acid, as I think some of you guys are already experts in, is an exam in which a woman has a speculum exam, a clinician examines the cervix, adds acetic acid, which is vinegar, widely available, and looks for any changes. It's really hard to tell in this picture, even close up, but there's a little white area there, and that would be considered a positive VIA. So in the best hands, so in well-trained hands, in many research studies, VIA has test characteristics that are comparable to cytology. It provides immediately available results, so it could be coupled with immediate referral or treatment. It's very inexpensive, and it's been shown to be cost-effective, and it doesn't require any lab or transfer facility. You just need to get the patient in a place where you can do a pelvic exam. The cons are that the accuracy really depends on the provider experience, so that depends on patient volume and continued supportive mentorship. There's no permanent record to review, which then feeds back to the quality that the providers have, that the providers perform the exams with. It can miss smaller lesions, and there's no way to test whether there's a lesion here inside the cervix. And then it requires a pelvic exam, so that's not a small burden. Most health facilities throughout Kenya should be equipped to do pelvic exams. They should be equipped to provide family planning and STI screening. They should have speculums and an autoclave, but that's just not the reality, and it's really hard to maintain. So they need the space, the privacy, the supplies and equipment, and doing a pelvic exam, even when all those things are present, there's still quite a bit of hesitancy on the part of the provider, and then on the part of the patient, and those sort of play into each other, and people can talk each other out of having a screening exam. So the third option is human papillomavirus or HPV testing, which I think many of us are familiar with because it's part of screening algorithms in the US. And it was really in its early stages of being available internationally when these guidelines were published in 2006. And the pros for HPV testing are that it provides a dichotomous result, positive or negative. Self-collection is possible. It's been validated in many studies, and there was a systematic review showing that self-collection has the same sensitivity and specificity for the cervical precancers as clinician collected. So you could take that exam out of the clinic, get rid of the need for a trained provider, and minimize the need for supplies and equipment. And it has a very high sensitivity. The cons are that it is expensive compared to the option of VIA. It's similar in cost, I think, to cytology. And has limited availability in many countries and has a low specificity. So a lot of women will be transiently infected with HPV but never have any sequela or development of precancer. So that could lead to overtreatment or unnecessary burden on the referral system. Okay, so that was the start. So the WHO came out with these recommendations. There was a really period, and I think it's continuing, of increased attention to and interest in providing cervical cancer screening. And after that came out, two really important trials came out that provided better evidence by which the WHO could make specific recommendations for what screening strategies actually work. So I'm going to briefly present these two trials. This is a really exciting trial for people who do HPV research and international work. It was funded by the International Agency for Research on Cancer. It's a huge trial carried out in India. It's a cluster randomized trial of 53 villages that included over 130,000 women. And villages were randomly assigned to offer cervical cancer screening to their inhabitants, their citizens, using either HPV testing, cytology, VIA, or standard care. Standard care was they didn't implement anything, but they made sure that whatever was existing at the local hospitals would be available for women. Women who had a positive result on any of these then had colposcopy and a biopsy if anything looked like it was precancerous. So they had professional outcomes for rates of disease in these in all of these villages, and then the outcome was cervical cancer incidence or mortality in 5 or 10 years. So the size and the scope of the study is interesting, and almost no study uses cancer incidence as an outcome, so this was a unique aspect of the study. The way they ascertained the outcome, though, was they looked in registers. They felt like the migration into and out of the villages was small enough that if they looked at the cancer registry data in 5 or 10 years, it would really reflect women or the population effects in those communities from when the screening took place 5 or 10 years ago. So I'm just going to present the main outcome. Their earlier data show that HPV and VIA were both as effective at 5 years in reducing the incidence of higher stage cancers and death. But at 10 years, they saw that HPV testing decreased the hazard of incidence of stage 2 or greater cancer and death from stage 2 or greater cancer by almost half. And VIA and pap smear at both of those time points did not show, villages that were randomized to those did not show statistically significant decreases in either the incidence of later stage cancer or death from cancer compared to the control group.
Can I ask, so
yeah,
in the overall rate of cancer, cervical cancer,
the top one?
Yeah, the rate per 100,000. It looks like the control group is the same as the HPV tested and lower than the other two. Is that just because the way of ascertaining cancer in the control group is just that? You said they did it through registries. But why is the rate per 100,000 per person year in the control group is 47.6 compared to the HPV testing is 47.4, and the other two are actually higher?
Oh, that's a good question. I know the overall rate of cancer, why the rates are equal or due to the lower stage cancers. Just having a pelvic exam allows for the diagnosis of early stage cancer. So I'm not sure though why the control rate and the HPV testing rate were the same in that, but I could unpack that. That's interesting. This just shows the same results graphically. So consistently, you can see HPV testing is in the orange triangles at the bottom of this graph. Consistently over the 8 years of follow-up, the incidence of the later stage cancer and the mortality from cancer were lowest in the HPV. Okay. So that was interesting. There were several aspects that were operationally similar to what would be introduced in a low resource setting. So it wasn't the final word, but it really provided a lot of important support for HPV testing. This was another trial. This was a randomized trial that took place in South Africa. It also had interim and final results. The interim results were published at the same time as the WHO guidelines, and then the final results came out a little later. In this trial, there were about 6,500 women, and they were randomized. They all underwent VIA and HPV testing, but they were randomized to treatment based on either their HPV results or their VIA results, or they underwent expectant management. So they had the test done, but no action was taken at that first visit. And then everyone underwent a colposcopy, which is that diagnostic step, and the biopsy at 6, 12, 24, and 36 months to ascertain how much disease there was at those time points. So in the first paper, their outcome was CIN2+. That is cervical intraepithelial neoplasia, and it's considered the cervical cancer precursor. So in their primary paper, they showed at 6 and 12 months, no difference, a benefit compared to the expectant management group, but they showed both HPV and VIA significantly reduced the detection of the cervical cancer precursors. And then they published their final paper, and they wanted to ask a second question: does it reduce the risk of developing cervical cancer precursors in the future? So lesions that appear at 12 and 24 months would be considered new. So can treating someone based on a visual exam or an HPV test reduce their risk in the future? And what they showed is that the HPV group, which also in this one is in red on the bottom, did have a significant increase in the incidence, a significant decrease in the incidence of new cervical precursor lesions. CIN grade 2, and then CIN grade 3, and that's just a little, CIN 2, 3 is just a little closer to cervical cancer. Okay, and then here we have the absolute numbers. The rate ratio at 36 months of follow-up for HPV was 0.27, so 73% reduction. And for CIN3, that reduction was even greater, rate ratio of 0.23. So really showed that HPV was effective, and if you look at visual inspection, it only reduced the rate by a third at CIN2+ by a third, and then was almost statistically significant for CIN3+. There weren't as many cases. But even if it was, HPV was more effective. So that those two trials played into the WHO's new guidelines, which came out in 2013. And the other important pieces of information that played into those guidelines were programmatic experiences. How were countries doing implementing VIA? What were some of the successes and barriers, and how feasible was introducing this visual exam in these countries? So the guidelines replaced the previous guidelines, and they actually made recommendations. They recommended that where feasible, HPV testing is preferable. Treatment should be based on screening results alone. They felt like the infrastructure necessary to confirm the diagnosis actually made the programs less effective because there was so much attrition between the different steps. And they recommended a single treatment modality. They recommended cryotherapy. They didn't say you could do this or this or this. They said cryotherapy, which is a modality where the cervix face is frozen for about 5 minutes. It's easily performed by non-physician clinicians, and it's widely available. They recommended that as the standard treatment. So they provided, we're not going to go through these, but they provided decision-making flow charts, not just handbooks of instructions, but really ways for people to think about how their programs could be structured to be most effective. They addressed programs that already had PAP or cytology-based screening programs, and they said that if they don't meet quality indicators, which is the true problem with cytology-based screening, then they should consider HPV. And then really importantly, they provided a very simple algorithm for screening and follow-up. So a lot of countries were developing their own algorithms, and this was able to replace what they had put into place. Very simple and straightforward follow-up. Okay, so both of these played into my work in Western Kenya. I started working there in 2006, moved there in 2007 to develop my cervical cancer screening program. So I really used that WHO guidebook from 2006 as my Bible and a reference when people ask me what I was doing. When I interacted with the Ministry of Health, when I talked to researchers or other funders, I sort of used that WHO guidebook from 2006 to say, we can do this, it's feasible, and let's support it. So I moved there and started working in an HIV care clinic. And the reason I did that is threefold, because my mentor had the clinic and was very enthusiastic about my the opportunity for me to work there. Cervical cancer is an important health risk for women with HIV, but also because the healthcare resources and infrastructure were in place, and I knew that if we could show a model that worked, then we could potentially scale it up to women regardless of their HIV status. So FACES, briefly, it's a PEPFAR-funded clinic, so it's a U.S. government-funded HIV care and treatment program. It's run primarily through UCSF in collaboration with the Kenya Medical Research Institute. It was started in 2003, and it's really evolved over the last 20 years to become more primarily led by Kenyan scientists and by leadership in the Kenya Ministry of Health. It currently supports HIV care for over 175,000 women in Western Kenya, and the majority of the people it supports are getting their care in Ministry of Health clinics in towns and rural areas around the Nyanza Province in Western Kenya. So after I finished my MPH, I moved there and developed a cervical cancer screening program and started training the clinicians. We nested it within the HIV care clinic to get some efficiencies so women could have the screening done as part of their HIV care visits, and we trained all of the providers so that they would be able to do VIA. We did clinic and community awareness building. We had these posters made. These are all patients who were very excited to be part of our campaign, and it was actually really important, and I'd like to say we did it first, but we didn't, and we learned from that. And it really was effective. We offered screening to all women 25 years or older with BIA, and we provided diagnosis with colposcopy and biopsy, and then treatment with LEAP. So it was a modified low-resource protocol. One, because the VIA hadn't really been validated in HIV-infected women at that time, and two, because we wanted to do some research studies. This is my fellowship project, so part of what I was doing was developing a cohort that then I could answer some clinical questions with. So to date, over 90% of eligible women at these urban hubs have been screened. And we were able to do a lot of evaluations from our cohort. We have about 10,000 women just from the 3 centers in Kisumu that have been followed for up to 5 years. We did some early analyses. We showed that the program was feasible. We showed that LEAP, performed by non-physicians, was safe and tolerable. We did 2 validation studies looking at visual inspection with acetic acid and another inspection method using iodine among HIV-infected women. We looked at genital shedding, so we got a small grant to look to see whether cervical, precancer, or cancer increased the risk of HIV shedding among women, and what was the impact of heart on that. We looked at whether having a biopsy at the time of colposcopy increased shedding, or whether having a LEAP procedure increased shedding, and we found that heart is very protective. There wasn't an appreciable increase except for a small blip shortly after the LEAP that returned to normal and was probably not clinically significant. We measured recurrence of disease after treatment at 6, 12, and 24 months, and we showed that LEAP was effective treatment for microinvasive cancer. What was happening is we diagnosed these early stage cancers, send them to the regional or the provincial hospital, and they would get lost. So we offered them treatment, and then we followed them closely, and women did not have recurrence of microinvasive cancer up to 36 months. And then we showed that screening within HIV care programs was cost effective. So all of this was the culmination of my fellowship project and some of the work that I did during my career development award, specifically the safety and validity pieces. But what my passion really was getting this getting screening and prevention out to women who had very poor access. And so we had the opportunity in 2012 to scale up screening in partnership with the Kenya Ministry of Health. Kenya came out with a cervical cancer prevention strategy in 2011, and the ministry was very interested in partnering with us because they had already worked closely with FACES for the HIV care. So we scaled up a very low resource algorithm, just VIA, and then we referred women for cryotherapy. We tried to design the program to be as sustainable as possible. The only thing we implemented that we knew would not be sustainable was a tablet-based data entry system so we could follow our outcomes and describe our cohort. And uptake was terrible. It was substantially lower than anticipated. We ran into problems at every step of the way, and this was with very carefully selected clinics, a lot of training and effort on the part of our team that had been so successful in Kisumu, and individual MOUs with every clinic that we worked with. And then among the women who had screening, we had some concerns about the quality of care. So this happened at a time where I was finishing my career development award, and I really knew, maybe this fed into my original passion, how can I get evidence-based WHO recommended cervical cancer prevention programs that should work in resource-limited settings? How come they're not working? So how can I study that? So the next step in my career was to write an R01, which would provide enough funding to look at this in a really systematic way. So I chose an implementation science framework to look at this question. I wanted to continue the observational work that we had done with some structured formative work to really look at where the gaps were. And then we defined 4 essential components of an effective cervical cancer prevention program: awareness for both and education for both the target population and the providers, an effective screening technology, notification of results in a way that women could understand and access, and linkage to safe and effective treatment. So the grant was written that we would use our context-specific preliminary data and work in partnership with the community and stakeholders to develop an effective implementation strategy for each of these 4 components. We would implement it, and then we would test it. So our formative work, we built on what we'd already done, and then we did some structured focus group discussions, in-depth interviews, site assessments, and provider surveys. We found, not surprisingly, there was a significant reluctance to undergo a pelvic exam on part of both the provider and the patient. And that was related to stigma, not necessarily stigma related to cervical cancer, but stigma related to being in a small town or a small community and having someone you know see you in what women considered an intimate position. Time and supplies, providers worried a lot about having the time or the supplies to do this, and there was a perceived difficulty on both the providers and the patient's part with addressing a very sensitive subject. There was a perceived lack of knowledge and willingness among the providers that was sensed by the patients. We found a lack of time and the lack of a presence of a skilled provider, so we were training people to do this intervention, and then the MOH would transfer them to a different clinic, or they would be gone that day, or they would just be gone when the patients, when the women showed up. The quality of the IA interpretation was difficult to maintain. The interpretation was variable between providers. The protocol was very confusing. The protocol that the WHO, or the Ministry of Health, developed in 2011, before that simplified WHO protocol, was incredibly difficult to understand, even for the reproductive health coordinators working for the MOH. So that was really dispiriting for a lot of the providers. And then space, equipment, and supplies were difficult to maintain. So we had the funding to ensure we had the supplies for this project, but gloves would go to where they were needed, or we just couldn't maintain this. And when it came time for the Ministry of Health to contribute their part of the supplies, they would have spent their budget on other health needs. So treatment availability, that was another challenge. We coupled the VIA with cryotherapy. It wasn't feasible to put in the small multiple rural clinics that we had. Gas and machines are expensive, they're difficult to source. There wasn't enough space or security in most of these small clinics. It was hard to maintain a trained staff member in each of these clinics, and the low volume of women both gave us concerns for the quality of care and for the cost effectiveness. So we set up referrals for treatment, but they have high rates of attrition due to the distance, time, cost, and availability of transport. Women really need to be counseled to understand the need for treatment. And then even when women made the trip, sometimes there was not a trained staff when they showed up for their treatment. And then women got a repeat visual inspection at the time that they were ready for treatment, and often that disagreed with their primary results, and they would get sent home without treatment. Okay, so based on the preliminary results, a review of the literature, and the WHO recommendation, we chose the screening technique, and we did some focus group discussions to talk about whether HPV testing would be acceptable in these settings. We chose HPV because low-cost HPV testing via Care HPV is becoming more widely available. It can be, they say $5 a test, it's between $5 and $10 a test. And it is a very low-tech strategy, so it doesn't require a trained lab technician or even a laboratory to be run in. It can be self-collected by the patient, so it addresses some of the barriers that we identified to screening. Specifically, this applies the time and the willingness for an exam, and there is a simple interpretation of the results, yes or no. And then there, nothing's perfect, so the screening challenges we felt still needed to be addressed were the education of providers and patients on the meaning of the results and the infrastructure development for the lab. So that's just the screening component. Then we wanted to talk about an implementation strategy for our screening technique, and that's the heart of the study. We think HPV testing is the way of the future, but how can we get HPV testing to women, to the most women, and have the greatest impact? So the standard of care would be to put HPV tests in the clinic and wait for women to come as part of their routine health care. So women don't get routine health care, but what a lot of people in Africa do are attend community health campaigns. There are preventive health screening campaigns and family planning campaigns that are high throughput campaigns. They have excellent mobilization efforts. They get the majority of the village out. They do screening for HIV, or testing for HIV. They'll do some blood pressure screening. They provide education and bed nets for malaria. So we felt like this might be a good solution for cervical cancer screening. We had done some highly attended cervical cancer screening pilot campaigns. Even with VIA, it was very highly attended. And it felt like an optimal strategy for periodic screening. If we could get the entire village out, we would know that we should go back in 5 years, and they didn't have to keep track of what their individual follow-up time was, because there is still not a system in the clinic to keep track. And we felt like the group messaging and the transfer of people and specimens would add some efficiencies. So we developed our 4-pronged approach. We filled out all the aspects of the implementation strategy using our preliminary data. We had a validated educational model. We were providing outreach, education, and screening in accessible locations using a model that had been successful within phases for male circumcision and for some of their other outreach activities. The screening test is the screening component is what I described. We are using text messaging, automated text messaging for notification of results. There's a huge burgeoning field of research and implementation science looking at health, and we're really optimistic about this. And then treatment, so there's a simple thing, what are we treating with? Cryotherapy, unless they're not a good candidate for it, as the WHO recommends. But linkage to treatment is not a small thing to address, and we felt like we did not have enough time to develop a linkage strategy while we're analyzing the screening strategy. So we proposed a 2-phase community randomized trial. The first phase, we're going to compare community health campaigns to clinic-based screening, and that's going to give us a sense of what's the optimal screening implementation strategy. And then in the second, in an interphase intervention development period of about 6 to 9 months, we're going to go back to these communities, work with the key stakeholders we've identified, work to trace women who had a positive test but didn't show up for screening, and find out what the barriers were, and work with the community so that they develop an enhanced linkage to treatment strategy. And I've been really careful not to say, well, we're going to try mobile treatment or transportation navigators or reimbursement for transportation. we want them to come up with a strategy that works for them. And already in the focus group discussions, there have been ideas that I would never have thought of that are simple. And so I'm really excited about this part of the design and this aspect of the study. And so then we will implement that strategy and evaluate it in 6 additional communities in phase 2. So this is a busy slide, but just to show that we have situated our analysis within the REAIM framework, which is an implementation science framework in which we measure reach, effectiveness, adoption, and maintenance, and implementation. So those are the questions, and these are how we're going to measure it. So reach, we want to see how many women get tested and what proportion of women in the communities that represent. Efficacy, how many women overall get treated, and what proportion of women who are HPV positive get treated. Adoption, we want to look at process measures for each arm of the study. Implementation, we're going to look at costs, cost effectiveness, and then we'll model population costs and strategy. So that's one aspect of the results. We're also going to look at process measures. We're going to do in-depth interviews after each aspect of the campaign. So what do we hope to learn from the study? I can't give you any results because it starts Monday. Our pilot program was phenomenally successful. It starts Monday. We had a campaign in a non-study community, and we got about 3 times the attendance that we were anticipating. We had a great experience with our notification of results. The lab glitches were totally addressable, so we're very optimistic about what we start. Monday really starts a busy 10-month period for the study. So our anticipated outcomes are, we hope to determine whether a community health campaign-based cervical cancer screening strategy is effective, acceptable, and cost-effective, especially as compared to a standard in the clinic. We want to really work with the community to develop that linkage to treatment strategy, and we want to provide a model or a toolkit for people coming to implement programs that sort of details how you work with the community and develop good relations, and then how you implement and test what you've implemented. And we want to push the widespread adoption of screening strategies at a regional or national level. So in broader conclusions, which many of us know, I think cervical cancer really exemplifies a global health disparity on many levels. It remains a huge burden of disease. And while challenges for cervical cancer differ between resource limited and resource complete, there really are evidence-based prevention strategies that we can implement. They just need to be implemented in a thoughtful and context-specific